This program is a WARREN STEIBEL production in association with South Carolina ETV. Funding for Firing Line is made possible by a grant from the John M. OLIN Foundation, the ANNENBERG Foundation, the Laurel Foundation, the Friends of Firing Line, and the people of Glaxo. In the relentless search for answers and medicines, on the brink of discovery, Glaxo, Research and Medicines.
The first two of our four-part series on national health and the magician circling around to make it cheaper, more comprehensive, more competitive, more formidable, and more popular focus primarily on the structural questions. How should a national program be set up? What are the logical component parts? This program and its successor will focus on the requirements and the velleities of the consumers of health care, which is to say, Americans with less than perfect health. And this appears to mean everybody. As with the first programs, we will rely heavily on the savoir-faire of Dr. John Goodman, the president of the National Center for Policy Analysis, a Dallas-based public policy research institute. Dr. Goodman, who has a PhD in economics from Columbia and has taught at 7 major colleges and universities while writing 7 books, has been a close student of health care. Indeed, his last book is called Patient Power, Solving America's Healthcare Crisis. We have a panel of distinguished and powerful men from whom we will be hearing, and I introduce them alphabetically. Robert Kenneth Dresing is vastly experienced in the medical health business. A graduate of Baldwin Wallace College, he's director of the National Institute of Health's Advisory Council. Ronald Pollack is executive director of Families USA, the national consumer advocate on health and long-term care. He has advised President and Mrs. Clinton on health care policy. Before joining Families USA, he was the dean of the Antioch University School of Law, having graduated from the New York University School of Law. He was the founding director of the Food Research and Action Center, the national anti-hunger advocacy organization. J. Rockefeller is senator from West Virginia, heavily engaged in a concern for national health. Senator Rockefeller is a graduate of Harvard. He did graduate work at Yale and served as president of West Virginia Wesleyan College before his election as governor of his state. He is an ardent champion of the Clinton plan. Charles Sanders is the chairman and chief executive officer of Glaxo, Inc., the pharmaceutical firm. He was for 8 years with the Squibb Company as vice chairman. He's a graduate of Southwestern Medical College at the University of Texas and has served as general director of the Massachusetts General Hospital as a professor of medicine at the Harvard Medical School. He's a member of the Institute of Medicine of the National Academy of Sciences and lives in Durham, North Carolina. And Senator Paul Wellstone from Minnesota is a renowned populist, a graduate of the University of North Carolina, where he also earned his PhD in political science. For 20 years, he taught the students of Carleton College in Minnesota and has introduced the American Health Security Act, which calls for a single-payer system of financing health insurance to be administered by the states under standards set by an American Health Security Board. Why not begin by asking Senator Wellstone to tell us exactly what a single-payer system is, and do we distinguish this from what we used to call socialized medicine?
Yes, I can talk about what it is, Bill, and yes, we can distinguish it from socialized medicine. First, just a little bit of background. At the Minnesota State Fair, which I insist is serious politics, half the state's population comes up to you in 13 days, and nobody has a lobbyist, and each person counts as one and no more than one. People basically don't talk all payer, no payer, single payer, payer, player, any of the rest of it. What people want to know is, Senator, will I be covered? Will my loved ones be covered? Senator, will it be a decent package of benefits? Senator, will I have a choice of doctor? and Senator, will it be affordable? Single payer gives
You
a
mean, will
resounding...
they, after whatever Congress gets done, or
That is
will
correct.
they now?
No, that is,
You're
after
talking to
Congress.
uninsured people?
Yeah, well, it's not just the uninsured people, it's people who are underinsured, and it's people who have a lot of insecurity about where it's all heading. And people want us to have major reform, but they want us to get it right. And they want to make sure that we meet that criteria. That's what single payer does. It's universal coverage, comparable benefits for each and every citizen.
Do they say, will I have inflation? Will I have savings?
Well, those people that are smart enough know that with a single payer system, a la, according to Congressional Budget Office study and General Accounting Office study, two very fine reports, this is the one way that you can go after the cost in the administrative bloat and provide really good services to people. So it's universal coverage, very comprehensive package of benefits, heavily tilted toward primary care, family doctors, absolute choice. We keep it in private sector. If you want to choose the fee-for-service, fine. If you want to belong to a health maintenance organization, fine. And it's affordable for 3 reasons. At each state, you have a single payer, not all sorts of different insurance companies. It can be the state, a public authority, or the state can contract out to one insurance company. GAO estimates that in 1993 dollars, Bill, you could save $100 billion just going after the administrative waste, which could be used to cover those people without insurance and those people that are underinsured. So that's really what single payer is. It's not government-run hospitals, it's not government-run clinics, it's not government-run doctors, it's within private sector, but we do streamline the insurance part of it, and frankly, I think the evidence is irrefutable and irreducible so far based upon the studies we see that this is the one way that you can clearly control costs and deliver really good care to people.
What did the GAO estimate the cost of Medicare would be?
What do you mean, what do they estimate the cost?
What did they estimate the cost of Medicare?
You mean when Medicare first was passed in 1965?
I'm taking a polite way of saying that the GAO's estimates haven't proved historically very accurate, have they?
Well, wait a minute. Do you know whether or not the GAO even did a study in 1965?
Yeah.
And what did they say
It
on
was
Medicare?
700% off.
The GAO study in Medicare was 700% off?
Yeah,
Well, I would say that the economic, let me just respond. I would say that the people that are doing the rigorous economic work, and I would also include the Congressional Budget Office, have learned a lot since 1965. You can't take a study back then, and I would say to my colleagues here in this discussion and debate that I don't know of another study, independent study, that has pointed to the kind of savings that you can have in the healthcare system while providing really good care to people out in the communities.
Okay, now I want to move on, but I just, what you told us was pretty much what the Clinton plan is, but I identified you with a hard preference for the single service.
No, this is quite, there are some similarities and some differences. Similarity is the focus on universal coverage and comprehensive benefits, but we streamline the administration. We dramatically limit the role of the insurance industry, which should be the case, and we set up a single payer at each state level. In addition, we're very strong on consumer choice. We don't make no distinction between whether people want to go fee-for-service or whether people want to belong to a health maintenance organization.
And Mr. Pollack, you would make a distinction, would you not?
Yeah, this is what Paul is describing is a proposal that he and his colleagues have introduced. The Clinton plan is not a single-payer bill, but it does achieve the kinds of objectives that Paul described. It makes sure that nobody would ever lose health insurance coverage again. Today, I don't know how many people here know, but each and every month, over 2 million Americans who have insurance lose insurance. Now, most of them lose it for a temporary period of time, but during that period of time, they are at risk of falling through the cracks. What the Clinton plan does is it makes sure that no matter what happens, whether you lose a job, whether you switch a job, whether you're a college student and you graduate from college and you're no longer eligible for your parents' policy, whether a company finds it unaffordable to provide coverage and wants to drop its employees, all of these people will be covered, and not only will they be covered, they'll have comprehensive coverage. And so the objectives that Paul's talking about are very similar in the Clinton bill, but it's a different method of achieving it.
Yeah, under the Senator Graham's bill, we heard a while ago, he would grant coverage for 18 months after you leave a job or get fired or whatever. What percentage of the people that you run into would that end up protecting?
You see, Bill, we already have a law that says, in effect, that you will get coverage if you can afford it. after you lose a job. Unfortunately, most people can't afford it. We have a piece of legislation currently on the books called COBRA, which says that if you get laid off from a job, you can get insurance, like the same insurance that your employer used to provide, but instead of your employer paying for it, the employee pays for it. But unfortunately, if you're out of work, then you can't pay for those premiums. Under the Clinton plan, people like that who have lost a job would be able to retain coverage, and to the extent that they had difficulties making payments during these periods of difficulties, they would receive subsidies from the government so they could afford the coverage that they used to take for granted.
Well, Dr. Goodman, what does the private sector or the opposition say about this particular problem, people who lose a job and can't afford to maintain their premiums?
We would say, first of all, that of the 37 million Americans who are currently uninsured, half of them will become insured within 6 months, 70% will become insured within a year, and that in fact the long-term uninsured only constitute about 4% of the population, and that, to handle the problems of the 4% is not an argument for going and socializing the entire system.
Would you be in favor of government guarantees to those 4%?
I would be in favor of government stepping in, creating medical savings accounts so that people would have money in order to pay premiums that Ron Pollack is talking about when they're between jobs, instead of turning all the money over to insurers or over to employers.
Your point is they shouldn't run out of money.
Well, that's right.
But John, you're also saying you're quite comfortable with 1 million Americans a month who lose their insurance, and 2 million and 1 million will not get it back for a period of 6 months. You're entirely comfortable to let them sit there for 6 months
No,
without
I'm not
insurance?
comfortable, and I think that's a consequence of an employer-based system which is encouraged and subsidized by
So it's
the
just a
federal
cost that
government.
society must pay, which you would rather
No, I
not
would like to
regret?
see insurance benefits be personal and portable so that individuals would take their insurance with them from job to job. Well, let me ask you something, Senator Rockefeller. Isn't the Clinton administration giving us the worst of both worlds? You've got the global budgets and the price controls that Canada has with all the weighting and rationing that implies. But for all the defects of the Canadian system, at least in Canada, you can choose your own doctor and you don't have bureaucracies telling doctors what to do. Clinton would force managed care on the American people, limit choice of doctors. People would not have access to drugs.
John, you've been reading the wrong magazines.
And you certainly haven't been reading the Clinton proposal. You know, the one thing about the Clinton proposal is it creates far greater choice than we've had before. As you know, John, more and more corporations and companies who are really staggered by increases in costs that they bear when they cover their employees, what they're doing in order to deal with those costs is they're saying to their employees, join this following HMO or join the following preferred provider organization, and if you don't like it, then you don't get any insurance coverage from us. And from 1990 to 1993, 3 times as many employers have told all their workers, take this plan or you're out in the cold. So people increasingly are losing choice.
Why are you
now,
on
what
the
the
code?
Clinton plan does is the Clinton plan says that the employer pays to a so-called health alliance, but the worker and the worker's family chooses which plan the worker and the worker's family will be in. So it's far greater choice than we're experiencing today, and far greater choice than we will be experiencing tomorrow if we don't get health care.
Could you, just to eliminate one question, why are you out in the cold if you can still go and buy Blue Cross?
No, what happens
you can't
is today,
afford Blue Cross.
today,
Well, you're not out in the cold.
No,
Yeah,
no,
yeah,
Bill,
in West Virginia,
you're out in
pay-
the cold if you have no money. In every situation.
Yeah, but
you can't buy a hamburger.
in West Virginia, if you want to buy Blue Cross Blue Shield for a family of 4, you've got to come up with $7,000 or $8,000, Bill.
Yeah, what's the matter with West Virginia, by the way? Because I heard the program in which you cited that figure, and the national figure is like $4,000.
That is correct, but it's
why
not.
are you so expensive in West Virginia?
I have no way of saying that. They don't run their operation very well, but $4,000 is not.
It wouldn't be
particularly good
prodigality,
bargain
would
either.
it? And
No,
government prodigality?
but Bill, we're missing the point. What happens is today most people get their coverage through their employer. The vast majority of Americans today get their coverage through their employer. Now, what the employers
But
are
that's
saying in
simply a
effect is take
historical
this
accident.
particular plan or you don't get any coverage from us. And that means that individuals have to come up with this money even though they're losing wages because the employer has already provided.
Why don't you, since we're in the business of reforming, why not change a World War II accident, which was that in order to beat the wage and price controls, you were permitted to give tax-free medical benefits. If the $100 per week that is paid in health benefits to an individual, $150 in West Virginia, would be paid in cash, and there were encouragement to take your own insurance policy, wouldn't that please you?
No, and the reason for that is, excuse me, Ron, is that leaves the consumer in the same terrible position where the consumer is today. You may have put $100 in his hand, or her hand, but he still has to go out and face the same insurance company, which has 30 or 40% overhead, and the cost of that insurance plan is going up 20 to 25% a year. If you're a small business, you're simply out in the cold because it's going up 25 to 40%.
Why is the overhead so high? Why is the overhead so high in the private sector? Who can answer that?
In the insurance business?
Yeah.
Well, because we have a system under which we encourage first dollar coverage by third-party payers, and in order to control costs, third-party payers are monitoring every bill and every expense. It's
So
a
by how
system
much
that's
would that be
inherently
reduced if
wasteful.
there were a deductible on the order of Phil Graham's?
Oh, if you paid a doctor bill with a healthcare debit card and you covered most doctors' expenses that way, we'd have administrative costs of 1%.
Yeah, the reason we've got such extraordinary expenses is that we've got 1,500 insurance companies with 1,500 sets of rules, 1,500 sets of forms, and doctors and hospitals are spending as much time filling out the forms and the paperwork for the insurance companies as they are practicing medicine. Now, what the Clinton plan would do is it would streamline.
That's scandalous, isn't it?
It is scandalous,
Yeah, I
of
agree.
course. And for small businesses, 40 cents out of the dollar for premiums that they pay for their workers is going for administrative costs. This isn't for good medicine. This is for paperwork. Now, what the Clinton proposal will do is it will streamline the system. We will not have this kind of tremendous blizzard of paperwork and the tremendous cost that it entails. We'll have a much more streamlined system, and so we'll be able to get health care at a more affordable price, and we can cover everything.
Just
I have a
as a matter of
perspective?
punctilio, we would have. We don't say we will have, because we haven't passed it yet, right?
No, but
Let me
we're-
ask-
we're-
Could I add a perspective
Let me
here
ask
real
Dr.
quick?
Let me ask Dr. Sanders the same question I asked Senator Rockefeller. Isn't it true that today with managed care programs, people are denied access to drugs that other people get access to, and that this is exactly the sort of thing we could expect with the Clinton administration program?
Well, the way I would answer that, John, is that I think, we're all for universal access. We're on the same page in terms of cost containment, in terms of access, portability, maintaining quality, and maintaining a commitment to research and innovation. That's what the
I think
American
it's too high in
systems...
West Virginia.
Well, maybe. On the other hand, I think it's very important that as we provide universal access and we provide quality care, that we make sure that the patients have the access to the broad array of treatment that's available. The thing that I am concerned about as a physician, having been a physician for 38 years now, is to make certain that I have available to me in any health plan those pharmaceuticals, for example, that are cost-effective, that will keep people out of the hospital, prevent the complications of disease. And when you talk about a very tough, cost-contained environment where you're really working to the bottom line, you may have a very short-term mentality. 1 year, if you're living within a global budget, Senator, that's the kind of mentality that it promotes. So I worry about, what kind of medicines are going to be available to our population.
Let me
under
respond very quickly
circumstances.
to a couple of points that have been made here that hopefully, add and it doesn't subtract from the discussion we're having. First of all, with John, there is a little bit of common ground I want to get to, but when I hear a discussion of the problem of rationing, it just strikes me that all you have to do is listen with your ears and just go out and meet people in this country. We ration by age, we ration by income, we ration by whether you're employed or not, we ration by where people live. That is one of the reasons why people in the United States of America have said, we want you to do well, we want to see some major health care reform. Second of all, in terms of the breadth of the problem, I think we make a mistake when we just focus on uninsured, as serious a problem as that is. The facts of the matter are that there are too many people in the United States of America who aren't old enough to receive Medicare. And even if they were, it doesn't cover catastrophic expenses, which is I had a mom and dad with Parkinson's disease. They're no longer alive, and I could talk about that struggle.
or people are not poor enough to receive Medicaid, and even if they are, it's by no means comprehensive and the reimbursement is totally inadequate and cost-shifted, or they are not well off enough, including many of our children, we have 3 children in their 20s, to purchase a decent health insurance plan. That is why, combined with business community, large and small, and combined with a lot of caregivers who I don't like to see scapegoated, doctors and nurses and others, there is such a hue and cry for reform. I just think we miss the very essence of that if we don't understand that people want us to do something about the twin problems of skyrocketing costs and plummeting security, combined with, and let me just finish, combined with finally are focusing on family doctors, nurse practitioners, physician assistants, getting care out of the community where people lived, backed up by specialization. If we don't make those changes, if we don't make those changes, then we will not have done well for people.
Well, we're going to make those changes. We're going to make those changes at a cost that I'm not sure everyone has clearly thought out. And I think that one of the problems that we're not hearing from the public is they have not seen the details of how these plans are going to work. And if you talk about solving all of the universal problems in this country concerning health care without looking at the specifics of what basic populations could be hurt by our reform, I think we're making a horrible mistake. And let me give you an example. But let me give you an example. A cystic fibrosis patient is alive today only because the fact that the pharmaceutical industry has provided us with tools to put these children in a holding pattern until ultimate therapies can be provided. A new drug that's coming on the market for the treatment of this disease is estimated to cost about $200 million for the cystic fibrosis patient population. It's going to be probably $10,000 per year per patient. Now, look at the system that we're devising that's going to provide for the oversight and the determination of whether this patient should get this drug or not. AHPs, which are all brought together on the basis who's the lowest cost.
What's an AHP?
Accountable health plan.
It's the accountable health plans. Those are the basic administrators or providers for the people who are going to be joining the various health plans and that companies are going to give you the choice of. Now, the choice is going to be determined from those AHPs. The reason they got to be one is because they're going to be the lowest cost provider, and they know that if they can't...
plan, not the single-payer plan, if you could be clear on that.
All right. Okay. In the president's plan, lowest cost. Now, lowest cost doesn't equate to value in this country. And medical technology is not going to be cheap. Curing AIDS is not going to be cheap. But who is going to make the decision on these panels or in these AHPs as to whether or not this is a drug that should be provided for a patient population, when in fact the long-term prospective studies on the value of that drug are never going to be considered because they're never going to get a chance to be in the arena.
What you're not saying here, and you should be saying, is that under the Clinton plan, for the first time, there will be guaranteed coverage for prescription drugs. There are 72 million Americans who do not have insurance coverage for prescription drugs. Medicare patients who really need prescription drugs the most, they don't have coverage for prescription
that's wonderful,
drugs.
and we're happy about that.
What the Clinton plan does
but what drugs are going to be there?
That no longer will anyone be denied prescription drug coverage, and Medicare patients are going to receive coverage through the Medicare program for prescription drugs. So
and
this
Ron,
is going to be a vast
that.
improvement
That's
from what we have today.
Ron,
that's the good
are
news.
you not aware that there are HMOs and managed care programs today that deny people access to drugs that other people get? And these are the very same HMOs and managed care programs that the Clinton administration wants to force everybody into.
I'm delighted to respond to that because one of the most important things.
I mean, you do agree with that. It's the existing HMOs and managed care programs.
Let him answer.
There are some health maintenance organizations that do deny care that should be provided. In any profession, there are groups that abuse the privileges, and there are some health maintenance organizations that are part of that. But what the Clinton administration's plan does
why are they selected?
Pardon me?
If they're so awful, why do they, you say you have 1,500 choices?
Because individuals today may select an HMO without knowing the information about the deficiencies of that plan. There are a couple of things that the Clinton plan will do that will improve that situation. Number one, for the first time, there's going to be systematic information developed about each plan, each health maintenance organization, and provided to consumers in that area that will give you exactly the kind of information you're talking about. If an HMO denies care to somebody, and they shouldn't have done so, that information will be provided to all consumers in that area during the time that they sign up for a plan. Secondly, The other thing that the Clinton plan does is it creates a process for appealing these denials of care, which don't exist today. So yes, there are some providers, unfortunately there are,
appealing to
who
whom?
abuse this, but now there are mechanisms to deal with those problems.
Appealing to whom? The courts?
No, what
Ombudsman.
each individual who is denied care, who should have received care, can go to an ombudsperson at the local health alliance level and can file a complaint concerning the denial of care. The Health Alliance will deal with that problem, and moreover, in the following year, when information is disseminated about the actual activities of each plan, they will be able to document the failure to
Let's
provide.
take a real-world
You
example.
have 30 seconds to comment on
Real-world example. Bob Dole is convinced he's alive today because he got a test for prostate cancer. Most HMOs and managed care programs won't give their patients this test. So you're telling me that the Clinton administration would force all the HMOs to give tests for prostate cancer, or would people like Senator Dole just be among the acceptable losses?
No,
You want a market determination on how many people want Senator Dole alive?
The entire emphasis of the Clinton plan is on preventive care, and as with women and mammograms and men prostate examinations, that will be, no matter what health care plan you're in, people are going to be pursuing you for those tests.
Thank you,
On Bob-
Senator. Thank
Yes,
you,
and
thank you, thank you, thank you. We'll be right back.
Funding for Firing Line was made possible by a grant from the John M. Olin Foundation, the Annenberg Foundation, the Laurel Foundation, the Friends of Firing Line, and the people of Glaxo. In the relentless search for answers and medicines, on the brink of discovery, Glaxo, Research and Medicines. For information about a video cassette of this program, write to Firing Line, 2700 Cypress Street, Columbia, South Carolina, 29205, or call 803-799-3449. That's Firing Line, 2700 Cypress Street, Columbia, South Carolina, 29205, or call 803-799-3449.